Hello, everyone, and welcome to the Down Syndrome Center of Western Pennsylvania podcast. As always, I'm your host, Dr. Kishore Velody, and we are so excited today to bring to you a topic that once again came to us from an email from a listener just like you who wanted to ask some questions about physical therapy. And as it turned out, during the National Down Syndrome Convention, I just so happened to be the moderator of a talk that our guest today, Helen Milligan, was giving. And so I thought, what a perfect way to bring it all together and answer this podcast listener's question about physical therapy, particularly in school-age children. But before we get too far, I thought, Helen, if you wouldn't mind, well, first of all, thank you for being a part of the podcast. And secondly, would you mind telling us a little bit more about who you are, what you do, and why you love working with people with Down syndrome?
Sure. Thank you, Dr. Milligan, for inviting me to your podcast. I'm honored to be a guest today. I am a physical therapist at the Children's Hospital at Philadelphia, and I've been a part of we call it our Trisomy 21 clinic for the last 17 years. I'm the physical therapist in the clinic, and our clinic has grown over the years to include babies all the way through adulthood. So we see babies, children, and adults in our clinic. And my initial interest in the clinic was because I have a son, Aiden, who is 18 years old now, and he has Down syndrome. So our clinic was starting, I was working at the Children's Hospital, and our clinic was starting just at the time that I had my son, Aiden. So he's taught me a lot, and I also have experience working for 15 years in early intervention, as well as being a physical therapist in the school system, as well as in rehab and in acute care prior to him, Aiden being born and me being a part of the clinic.
Wow, that's so great. So you're coming at it from so many different angles in terms of this listener's question, which really was interesting, focusing kind of on we know that we have birth to 3 or early intervention programs that are in place for kids until they're 3 years of age. And we both work in the same state. And I think you would agree, we have some really great early intervention services in our state and ability for the kids that we follow to be able to access those services. But why don't you start off just a little bit, tell us about the early intervention programs that exist. What do they do? And before the kids get into that school age, how can they be helpful?
Oh, sure. I'd love to. So early intervention are services that are funded by this state as well as the federal government, and each state runs their early intervention programs a little bit differently. So I previously lived in Atlanta and was an early intervention provider there, where the services were not 100% covered by the state. But you're right, Dr. Velody, we're very lucky in the state of Pennsylvania in that all of our families are qualified and receive early intervention services free of charge to them personally. And early intervention is really focused on supporting the family and supporting the child in the home environment, in the natural environment. And so the physical therapist works with children in the home, and really it's a coaching model, so that our goal is to include the family, include the siblings and the parents, with the hope that whatever we're working on with the child or teaching the child, that the family feels comfortable following through with everything when we walk out the door. And that model is actually very different than, say, the school-based model, or a model that you would see in the outpatient setting. So if your child's receiving outpatient services as well as early intervention, outpatient services are more episodic care. So they would focus more on reaching certain functional goals that the child might want to achieve. So for an example, I'm seeing about 3 children right now with Down syndrome. They're about 2.5. They're about to start preschool in the fall, and we're really focusing in on helping them learn how to walk safely up and down the stairs, so that when they start preschool, they have that skill of walking up and down the stairs safely. They'll be able to be a part of their preschool class. And so I'm seeing them in the outpatient setting to give them a little boost, and so that we can get the amount of practice they need, as well as giving the family tips so that they can follow through with their program at home.
So definitely the focus, it seems, as you're saying, kind of changes as they go from the early intervention, I would assume then until they get to those school-based therapies. What are some things that families have brought to you or that you've seen in your own experience as maybe some challenges, some differences between the early intervention services and then as the kids get to that more school age for physical therapy in particular?
Great question. So there's a big difference between early intervention birth to 3, which is really focused on the family and the home model, and it's definitely a coaching model. And it should be really what the parents want to work on. That's what your therapist in early intervention should be supporting you and the family. And then as your child turns 3 and they move away from their IFSP, which is the individual family service plan, into an IEP, which is an individual education plan, it's really academic or education based. So at that point, services are provided in either a preschool setting, sometimes that's the daycare, and then once they reach kindergarten and first grade, the services are provided actually in the school. And again, those services are academic and education based. So the goal of the therapist or the focus of the therapist is helping the child receive that free and public education in the least restrictive environment and helping that child reach their full potential in the academic environment. So the goal isn't to meet all of their, say, what the parent might think of all of their physical therapy needs necessarily, or their physical needs, but it has to be based on them accessing their curriculum. So doing stairs, walking up and down stairs would be a great goal in the school setting if there's stairs in the school. Accessing the playground, being safe on the playground, walking in the halls, participating in gym class with the whole focus on participating in that academic program.
So the academics really becomes the focus. And I think this kind of ties in then with even the question as we're getting closer to really addressing the specific listener's question, but just this idea of give us of what is like pushing in and what's pulling out. You know, you'll hear these terminologies quite a bit when it comes to the school-based therapies. What's the difference between a therapy that pushes in or one that pulls out? What are those things meaning?
Another great question. So a push-in model for physical therapy is when the physical therapist is involved and in the classroom or with the students in whatever the activity might be. So say a push-in model for physical therapy might be me as the therapist coming to the playground during playground time and being a part of the child participating in the playground, on the playground with their peers, with their friends, or participating in the gym class if they need some support and extra help in the gym class. That would be more of a push-in during the regular routines of the classroom with the other classroom students. And we also, you might find that push-in model is really the early intervention model as well, where the therapist, when I would work in daycares and I would come into the daycare, most of the time I would stay within the daycare classroom and try and do some movement, some set up little obstacle courses, and or if it's the ball skills, include their peers, include their friends in the therapy session. So that would be more of a push-in model. A pull-out model would be when you take the student, take them out of the classroom and work on a particular skill outside of the typical time that the child would be doing this skill during the school day. So for example, if you're again focusing on the steps, which is a big area for our kids with Down syndrome that they need practice on walking up and down the stairs both safely and efficiently. Typically, I would want to pull that child out so that we could get enough repetition and practice. If we're going to change, say, the child's walking up and down the stairs, but they're putting both feet on each step instead of doing one foot or alternating feet. That's going to take a lot of repetition and a lot of practice to change that motor skill for that student. So just doing it the one time that they might do it, say, when they go to their classroom down to lunch, that's not going to be enough time and enough practice. Also, it's in a really distracting environment with lots of other children around, lots of noise, and it's also not the best time to work on that skill, maybe because the child wants to keep up with their peers and wants to be a part of the group. So pulling them out and working on it at another time, giving them the amount of repetition and practice that they're going to need, and then maybe following through as a consult and checking in with them and asking the teacher, asking the one-on-one aide, how are they doing, following through with that during the transition times of the regular school day. That would be more of a pull-out model.
Okay, that's really helpful. So looking at this specific question that we got, so this came from a mother of a 10-year-old, and she was noticing that the school contacted her and said that her child is not cooperating well, not making progress. They made a comment that older kids with Down syndrome usually hit a plateau, and that she should be spending more of her time in classes than in getting the physical therapy. But this mother has noted her child has a hard time with core strength and being able to sit at a desk and have the balance that she needs. And even I guess the PTs have noticed the same thing, that she doesn't have that strength. But what she noticed is that the school is saying that they won't do push in, they'll only pull her out of the classroom. So it seems like two different things. One is saying that she won't progress, but the other is saying she needs to be pulled out. So I could feel the exasperation in the email and saying, what do I do? And so I don't know if you have an easy solution or some thought processes that maybe could help to answer some of those questions.
This is actually something that is a common question or a common issue that comes up in clinic with a lot of our 10-year-old students and children with Down syndrome, because they're at that age, maybe they're third, fourth, fifth grade, where they're actually doing quite well accessing the environment. Is from a physical therapy perspective, they're able to go up and down the stairs safely. They're able to go out on the playground and play. They're keeping up with their peers, but yet parents are really confused and frustrated because the therapist might say, well, it's time for us to discharge physical therapy at school. And it's really confusing because you see how your child is still, weak in their core, and their balance isn't just like other children's balance. So this comes up a lot. I see this a lot in clinic. And at this point, though, if the child is accessing their curriculum, it's probably safe to say that it's an okay time to stop physical therapy in school, because the child, you do not want to be pulling the child away from their academic, especially their academic curriculum, to work on skills that really aren't affecting them accessing their academic skills. However, most of the time, our kids can still benefit from exercise and balance training and core strength. And that's something that really we're going to be working on, and something I address in clinic for the rest of our kids' lives. I'm always looking at that and giving activities and exercises to keep their core strong, to work on the next balance skills. But it doesn't necessarily mean that they have to have PT in school. Now, that being said, she had a great point about the fact that the child is having a hard time sitting at their desk for long periods of time because of their core and core strength. It could also be it just could also be that the child might need to get up and move and needs movement breaks. So one thing I always included in my son Aiden's IEP in the specially designed instruction area was that somebody, either the OT or the PT, would go into Aiden's classroom and make sure that it was sitting correctly, so that he had the correct chair to sit in that was supporting him, that his feet were flat on the floor, that his back was supported. Because if our kids have their feet dangling all day long, they're never going to be able to really participate and feel supported. And it's taking too much work for them just to sit. So that how are they going to do their handwriting? How are they going to eat down at the cafeteria safely? And so that really should be a part of all our kids' IEPs in this specially designed instruction, that someone evaluate the sitting posture in all areas of the school day, including the classroom, if they go to art, if they have music class, when they're down in the cafeteria. And, a whole nother separate area is looking at their pelvic health and making sure that they also have the right position if and when they're using the toilet in school.
So those would all be areas that would be looking at those same muscle groups and working in those same areas. Is that what you're saying?
Well, what a therapist could do is go into all those different areas, and that would be put in on a consult basis. So that wouldn't be a weekly therapy pull out, push in type of service, but more of a consult. So the different ways you can have a therapist involved in your school day is, active weekly therapy sessions. And then you could do a consult model where they come in either quarterly, once a year, just to check their seating position when they're older. And that would be more of a consult model.
Got it. That's helpful. Okay. So if a family feels like the therapies that they're hoping for, physical therapies that they're hoping for, are not really, they're not impacting the child academically, so the school is not necessarily going to address them, what would be some suggestions that you might have if families are looking for therapies that they don't feel that the school could provide adequately? Where would you have them turn to?
So we have to, as a physical therapist, what I'm thinking of right from the beginning when I'm starting to see kids, even in early intervention, and when the kids are coming into our clinic, I'm thinking about, how are we going to stay active? What are ways that each child can participate and stay active really for a lifetime? So we have to start thinking of more in the model of participation. And what things can our kids do, because they're not going to be able to be involved. Physical therapy should not be a part of our kids' life on a weekly basis forever, but they all need to stay active and stay fit and stay healthy. Physical therapy can get weaned out of the school setting, and then you could consult the physical therapy through a clinic model, through an outpatient model where you come in and receive a physical therapy evaluation. The therapist might give you certain stretches or strengthening exercises or activities to do, or may even start a short episode of care where you come in for a few weeks of therapy. We give you activities to do, but we want to eventually transition and shift to your child participating in some kind of activity on a regular basis, whether it be going on hikes, swimming, dancing, karate. So that's where, as a parent, we really have to stop thinking about always coming in constantly for physical therapy, and then thinking about us as being like the coach and kind of helping you move to more of a participation in an activity model.
That's exciting. Yeah, that really makes sense. Well, Helen, I really appreciate all this information you've shared and being able to answer this listener's question with your expert advice. Is there anything that we didn't talk about today that you want to make sure that people know when it comes to physical therapy and in the school, and especially for kids who are older?
Sure. Well, first of all, when your child is receiving physical therapy in school, one thing to look at that I would recommend in the younger grades, that try to get the physical therapist involved with possibly doing some pre-teaching, especially when you're talking about having kids included more. So we do pre-teaching for other subjects like social studies and math, where you can pre-teach the subjects prior to the child actually learning them in the class so that they have a nice foundation. And I typically used to do that as a school physical therapist. So the PT can find out what the curriculum is in the gym program and actually pre-teach some of those skills in the PT session. So if they're going to be doing jumping jacks, that's a big one. I can pre-teach that skill so that the child already knows how to do jumping jacks before they're doing it in the gym class, so the child can participate more fully in the gym class. If they're going to be doing a certain sport, you could play it with them one-on-one so that then they can become more included when they do have gym. Stairs is a big one. So our kids can typically go up and down the stairs, but many times I'll see our teenagers come in and they're still putting 2 feet on each step, or they're not as efficient. So I always do a stair test with everybody on the stairs. I watch their gait pattern. I time them on the stairs. We want our kids to be going up and down a full flight of stairs in about 12 seconds. And then I often ask them to come in with their backpack and look at them walking up and down the stairs with the backpack. I know my son, he played the trombone for a while, and he was up on the 3rd floor. So he had a backpack, a trombone, plus he had to go all the way up and down the stairs with that. So that again, the playground skills. And then another area that a PT can work on is walking in the hallways, as well as carrying a lunch tray in the lunchroom and being able to balance that tray and keep up with their friends. Again, always look at the seating areas. And then once your child is just discharge, remember to consult a PT for areas as they're growing and developing. I mean, therapists should be looking at their shoes, looking at their orthotics as they're growing and changing for their balance, helping you with participation if there's certain things that are making it difficult for your child to, say, participate in a karate class or a gym class. Sometimes we can help. We can help guide you with some motor planning techniques. Somebody should be looking at orthopedic issues, including their hips, their feet, their spine as they're growing, checking their flexibility. Oftentimes when someone's walking on a pronated with their feet pronated for years and years and years, their hamstrings can get tight, and especially when they're growing. And then looking at their endurance and their posture. So those are all things that we continue to look at in our clinic at SHOP and give suggestions for home programming ideas or things out in the community that can help them, stay active, stay fit, and reach their full potential.
Wow, that's fantastic. I have to tell you, all the talking about doing jumping jacks and karate, I'm getting tired even just thinking about it. You guys have to stay in shape too as physical therapists to do all those things.
That's true.
Yes. Well, thank you again so much. And I really appreciate you coming on with us and being able to share this information. For our listeners, I hope that you found this as educational as I did today, and learning more about physical therapy and the role of physical therapy all throughout the lifespan of somebody with Down syndrome, and how we can use their expertise for our kids to be able to succeed and thrive in school and beyond. Helen, I appreciate your time today, and thanks again for coming on.
Oh, sure. My pleasure. Thanks for having me.
Of course. And to our listeners, please stay tuned. Of course, we always have more podcasts on the way. Please send us your questions again to Down Syndrome Center at chp.edu. We will gladly reach out and find experts to help to answer those questions for you. And in the meantime, until next time, bye-bye.